Namaste, I am Dr. Vivek Singh, and on behalf of NEDOL, I would like to welcome you all to the platform. NEDOL Nepalese Doctors Lounge in initiation taken 2 months back, creating a virtual platform for the Nepalese doctors to share ideas and innovations, and joining hands together to convert those ideas into project. In last 60 days, we have accommodated 9,300 doctors and has a target to reach 15,000 doctors by the end of first year. We have three mottos: non-political, respect others' opinion, and help others to rise. Similarly, NEDOL has three sections: NEDOL for doctors, NEDOL for public, and NEDOL for medical students. Talking about today's webinar, the topic for today's webinar is central catecholamine blockade by clonidine prevent SAR-Cov2 related complications. The topic will be presented by Dr. Sanjiv Hyoju. Dr. Sanjiv is a 2000 batch of Manipal Pokhara. In 2010, he completed his MS General Surgery from BPKIHS. He is a Harvard-trained researcher. He completed Ph.D. from University of Chicago and Radboud University, Netherlands. And today he will be talking about the topic. I hope you will have a great discussion. Handing over this to Dr. Sanjeev. Thank you.
Thank you very much for giving me opportunity, Dr. Robin and Dr. Vivek and NEDOL. So I'm really excited to present my opinion, my view on this SARS-CoV related on this topic through this webinar. So before I start topic per se, I would like to give a little bit backgrounds. As Dr. Vivek already told you about my backgrounds, but so I've been doing research here at the University of Chicago for almost like 6-7 years, and my area of interest is microbiome, sepsis, immune system, and bacteria. So I'm defending my PhD on the non-antibiotic, non-virulent approach to prevent the anastomosis leak and sepsis. I'm very privileged to have a great mentors, who is a renowned surgeon scientist, Professor John C. Albury from University of Chicago, Professor Harry Van Gogh from Radboud University in Netherlands, and Professor Olga Jabarina from the University of Chicago. So it's my great honor to have such a giant as a mentors, and under whom I'm getting my PhD. So as so far, my conclusion from the research is like a broad spectrum antibiotics are not appropriate for management of sepsis. And we have incomplete understanding regarding pathophysiology of obesities. And there are many ways to bring optimal interaction between the host versus bacteria, virus, and fungi. So both are benefited. So with this, like we now are in the COVID pandemic. So I did a deep research on the COVID pandemic, COVID-19 also, because of my research background. And I proposed the hypothesis, so based upon which we can mitigate the COVID symptoms, like a central catecholaminergic blockade will prevent, with clonidine, prevent the SARS-CoV-2 complications. And this is what I'm going to talk about today. So exactly a year ago, on 27 May 2020, I proposed the hypothesis that SARS-CoV-2 and the sympathetic immune response can be dampened, inflammation can be dampened by the antihypertensive drug like a clonidine and propranolol. I have proposed that the peoples which are chronically sympathetic hyperesthetics with the comorbid conditions who then contracted the SARS-CoV-2 virus can potentially drive the infection toward the fatal outcome due to the excessive catecholamine release and the cytokine spillage. And this is the graph which I speculated, which I'm going to explain here. Like what happened when the patient contracted with the COVID virus. With increasing durations, and there is an increasing sympathetic overactivities. And with the age, as I said, like the once we get older and older, the sympathetic activities also increases. And on the top of that, the chronic medical illness like diabetes, hypertension, and obesities. If all these factors are there, with increasing duration of COVID infections, the sympathetic overactivity keep increasing, and the more it increases, the worse outcome it will be. this is all my speculations. So, and based upon this speculation, what I thought is the simple clonidine, which is alpha 2 agonist drug, may be a plausible mechanism to override the T cell exhaustion, cytokine spillage, and the impaired virus clearance. After that, after my publication, there are many publications many scientists around the world have put their view regarding the autonomic nervous systems and the COVID-19. You can see this is one they put their view about the happy hypoxia, and they suspected it is due to the autonomic interoceptions, and it's already been proven. So there is a publication in Lancet where you can see where they did the biopsy of the brain who died with the severe COVID, and they found the inflammations around the brain streams. It's a main nucleus, that's autonomic center, which is nucleus tactus solitarius, rostral ventrolateral medullas, and with this, we can speculate that in some patients the response is really erratic. Like you can hear the patient dying at the gate of emergency when he's totally fine half an hour ago. So this kind of stuff happen because it's affecting the autonomic nervous system, which is the main center of our body. And beside this, there are other publication viewpoint also which have a similar thought about mine, but they include all other stuff like angiotensin converting enzyme involvement, and they have discussed that. This is another paper from the NIS neuroscientists who well describe this autonomic, how the COVID-19 affect the autonomic nervous system and how it's caused dyshomeostasis and all the comorbid conditions. So, and here is another viewpoint which is published in October 28th. So here also, it's also from the NIH. Here also they have put a view about the catecholamines and physiology and the implication of COVID-19 patients. I really don't want to go in detail about the viewpoint, so I just want to focus about what I wrote at that time in my medical hypothesis. So that's what I'm going to describe now. So for me, you can see there are lots of people not having even though having a COVID, don't have symptoms like myself. When I got the COVID, I just have a simple flu-like symptoms and simple myalgia. That's it. It's for the 2 days and it's gone. I'm COVID positive. I have an IgG COVID antibody. So, but there are the patient who's immediate, as I said, who's died, and lots of people are died, like almost like 500,000 people died. So what does this mean? This means for me, the COVID-2 is not itself is a lethal virus, because it's an interaction between this virus and the immune cells that ultimately direct the response and which direction you are going, and this is controlled by the brains to the brain immune pathway by the norepinephrine and cytokines. And there is the neurotransmitters, the sympathetic neurotransmitter, which is norepinephrine. It's modulate all these immune cells by the adrenergic receptor. And this is the graph. This is the graph where which well explain about how norepinephrine's affect the immune cells. Here what you are seeing in the green in the green color is like a normal conditions. What happened in the normal conditions? The immune cells have only one or few these adrenergic receptors, and then when the normal condition people got stressed, there is a surge of norepinephrine. They act on these few receptors, and and it causes the inflammation, which is really important for our body. But these inflammation are localized. They are for the certain specific period of time, and after that the inflammation subside. And this is the body normal tendency. It's a normal mechanism to cope up the stress, But what happened in the RAID, you can see in the chronic stress situation, the immune cell has a more density of this, express the more density of this adrenergic receptors. So the chronic stress situation, as I told earlier, is a chronic medical condition, which is diabetes, obesity, cancer, heart disease, stroke, respiratory disease. So in these patients, what happened is, like, there is chronically spillage of this norepinephrine in the body, and then on the top of that, when these and in order for this immune cell to adjust that continuous spillage, they increase their expression of this receptor, adrenergic receptor. So they have more density of adrenergic receptor. And then when such people got stressed, with the same amount of norepinephrine also, like when there is a with the same amount of increment norepinephrine spillage, the response is erratic. That means, like, they have a ultra-inflammatory response that may drive to the cytokine storm. And among these storm, IL-6 is one of the cytokines which is the leading cause for tissue damage, and then multi-organ failure. And the tocilizumab is one of the drug that block these IL-6 and is currently in the COVID-19 clinical trials, right? So there is not many publication or not many basic science research regarding the COVID virus and sympathetic activity. So, but definitely, if you search the literature, so you can see a lot of review article or publication regarding these sympathetic activity and the influenza virus. And it's saying that with increased sympathetic activity, the influenza virus is, the infection is get worsened. So this is one of the publication where they use the neurotoxic drug. It's a 6-hydroxydopamines that damage the norepinephrine releasing nerve terminals. So what they found is, after ablating the sympathetic tones, when they infect the mice with the lethal influenza virus, they found that the lungs pneumonia, development of viral pneumonia, is significantly less with the 6-hydroxydopamine treatment group as compared to the controls, where there is like a lots of the mice develop pneumonia. And then the percentage survival is significantly improved with 6-hydroxydopamine. Similarly, the drug like the beta blocker, NEDOL, have a increased response of interferon gamma, which is the antiviral response. So these all are blocking the catecholamine released, And then there is another drug, which is clonidine, which shows which upon treatment with the mice found that there is significant improvement in the survivals. And interestingly, the viral replication is significantly decreased when the dose of clonidine is increased from 0.001 to 0.1. And this is really striking for me, as this is not an antiviral drug. So it's all about the interaction between the virus and our sympathetic nervous systems that drive the immune cells toward the more fatal outcomes. So let's talk about how the catecholamine serves its effect to our body. So it's prone to cause the oxidative damage to the tissue by releasing off ions, free ions. So what happens when there is an injury? So initial injury like a trauma, sepsis, that cause the catecholaminergic surge as a stress response, which is generally a normal phenomenon, but that caused the release increased iron and caused the tissue injury. So this has to be stopped at some point, and the inflammation should be subside, and that will cause the recovery. But what happens if there is more iron release, more tissue injury? It ultimately drives this response toward the multi-organ failure, and this is what happened in the trauma and sepsis. So what I believe is SARS-CoV-2 is also a stress. When we have contracted with the SARS-CoV, that caused the stress. It caused the catecholamine surge. It caused the serum free iron release in our body, and that caused the oxidative stress and ultimately caused the tissue damage, like a pneumonia. So the pneumonia is more common here, but what we have to think is the sympathetic activity is not equal in all our body part. Like a heart has a most highest activities outflow, and then followed by the kidney, and then the GI tract and the lungs. So one should think about this. That's it's not equal. So the concept we have is like a sympathetic activity is equal to our body. It's not like that. So they basically so with this, one can assume that when there is more sympathetic outflow to one organs, that organ's likely to fail. Like for example, the kidney. When they have more activities to the kidney, as you can see, the patient with the chronic renal failure, they develop chronic renal failure. So what I'm assuming here, there is more activities, sympathetic activity toward the lungs. That's the patient start developing pneumonia, and then these increased irons is bind by the ferritins, which is the body one protective mechanism. So the ferritin is a marker for the SARS-CoV-2 related complications, right? So the more increase in catecholamine, there is a more oxidative stress. The body will produce more serum ferritins. That will lead to the more complications. So one can assume that when there is high ferritin levels, the catecholamines in the body might be in the higher states. What happened to what happened to the effect of catecholamines to all organs? Let's see this. So in the lungs, as I said, it caused the alveolar damage. How? Because the sympathetic outflow is more predominant also in the vessels. It constricts the vessels, and it caused the VQ mismatch, and then it caused the hypoxia, right? So I have seen the patient literally dying because of gasping. Their blood pressure is like 140/80, but pulse rate is like around 80, but the saturation is 60. That's how they are dying within the 15 minutes. So it's really very sad that and I feel like this is what the mechanism is. And the another one is effect in the heart. The patient immediately die with the heart failure. So you guys might have heard about these Takotsubo myocarditis, which is the pathophysiology is intense catecholaminergic surge in the heart, and that caused the wall necrosis, and the patient ultimately died with the arrhythmia and the heart failure. And this is same happened to the COVID patient also in some of the COVID patients. One of my close relatives, who was 82 years grandma, died last week with the single spike of 105 fever, and immediately developed the heart failure. So this is what happened in the COVID. And then also the hyperglycemia. You can one of my close relatives also developed hyperglycemia. His blood sugar was 1200, and he had to go for frequently for micturition. So this is what happened in the catecholamines. It's altered the islet cells, and that caused the hampered the insulin release, and the blood sugar spike up, and that's lead to the hyperglycemia. Similarly, the catecholamine caused the renal release from the kidney, caused the vasoconstrictions and hypertension and renal failure. And then also the catecholamine is liable to cause the hypercoagulation and thrombosis. And then definitely cytokine storm, as I explained earlier. So these all pathophysiology can be explained with the simple neurological pathophysiology, that the catecholamines caused by the catecholamine. So this is all fit in the COVID, and this is one of the viewpoint from the renowned neuroscientist published in the Lancet journal. So with this, what I think was, initially I published the hypothesis, but I'm not sure it will work or not. But when it's at the very beginning of first wave in Kathmandu, one of my close family member got contacted with the COVID, and we tried all the stuff. It didn't work. So she was hypertensive, and she had every day she had a spike of 105 fevers, and then her oxygen saturation was also gradually in the trending down. So eventually we decided to start the clonidine, and and it was really amazing to see her response. Like within 2 days of clonidine treatments, her condition started improving really drastically. Like she become feeling really fine, and it was really rewarding. So with that experience, I thought like I should I should I should consult people over there, like my close, near and dear relatives. So I opened this COVID-19 response group, and then start consulting patients from here, and also treating them with the clonidine. So I'm going to discuss like few of these cases. I submitted it for the publication also. I already explained about these figures. So based upon that, what I did was I gradually increase this clonidine level, as you can see, from 100, 200, 300, 400. So the whole idea here is to break this chain, the break this chain of sympathetic overactivities. And once this patient reach up to the maximum, that's one of the two of my patients here, they receive almost like 400 microgram of clonidine, and their symptoms become really stable. So now they have more improved oxygenations, they have more they are not having any spike of fever. So after that, I just keep these doses at same time for like few days, and then gradually taper off. This is what the graph is showing that. So this is the CT scan of those patients. So patient 1 has a very mild symptoms, whereas a patient 2 and patient 3 have a moderate disease burden. They have a pneumonia, they are hypoxia, they require oxygens. So another aspect of COVID-19 beside pneumonia is also the right heart failure. So we should be really mindful here, and I want to share my experience. It was like 2 weeks ago when one of my close relatives' whole family got infected with COVID, and then out of 5, 3 needed oxygen supplementation. It's a very difficult time for me and my wife here managing managing my relatives. Like, because at that time the ICU was also full. Within like 3 days of fever, they start having hypoxia, they start having hemoptysis, and their oxygen saturation drop up to the 65%. The SpO2 drop of 65% even with a slight movement. Like, and it was very scary. It was very scary. So what I did was, like, I told them to have their vital charting. That's the temperatures, blood pressure, heart rate, and oxygen saturation every 4 hourly, and they send it to me. So based upon that, I treat them. And then I also, like, I have back in mind that this could be due to the right heart dysfunction also. So what I did was I sent their pro BNP, and it was really high. Like you can see, the one of my patients have like 20,000 picogram per ml, and other have 8,623. So what does this mean? This mean is like they are pending, their right heart is dysfunctions because of this COVID. And and um, and then, like, that's how their oxygen saturation is dropped even with a slight movement. This is what I'm thinking retrospectively. And after this, what I did, like, I start treating them with the clonidine with 100 microgram every 4 hourly. Like charting their vitals, like a blood pressure and the heart rate. And so we need to be really mindful regarding the COVID while managing the COVID patients, that they might have this heart condition also. So not beside the pneumonia. Yes, pneumonia is also the one of the reasons that causing the hypoxia, but beside that, because of this pulmonary hypertension, they maybe land up with the right heart, ultimately land up with the right heart ventricular right heart failures. So in these patient categories, what happened if we give like more IV fluids and the plasma therapy? Definitely it will be more harmful. So we should be very mindful, and not and think about this scenario also. If the patient is not improving, if the patient is hypoxic even with the high flow of oxygens. So this is all about how the clonidine is intervening the pathophysiology of COVID, and most of them are speculated. This is what I thought, and it's working perfectly to all my patients. So beside that, like I also want to tell you about the additional benefit of clonidines. Like what happened in the COVID-19 patients, they have anxiety, they have insomnia, they have diarrhea, they have whole body ache, they have cough, they have intense headache, right? So all the patients have these kind of symptoms. So the clonidine is like a like a magic drug for this patient. You know, they have anxiety, the anxiolytic, the clonidine has the anxiolytic properties. Their anxiety gets reduced, they could not sleep. You know, the clonidine has a sedative effect, they sleep well. And then the diarrhea, the clonidine has an anti-diarrhea effect. If you search in the literature, you'll find it, the clonidine is used in the irritable bowel syndrome. And then the analgesic effect of clonidine is very helpful to prevent the whole body ache. Similarly, antitussive effect is useful to prevent the cough. What happened? These patients have a really hacking cough. You know, they can't stop, like they can't stop. They continue coughing, coughing, coughing every time they keep coughing. You know, and that's like whole muscles start painful. That's what happened to my patients. So with the increasing clonidine, they got relief. They got relief from the cough also. And then because of the intense vasoconstriction of the blood vessels in the brains, they have intense headache. I have a patient who literally crying because of headache. Even my wife has intense headache, right? So like when we give the clonidine, you can hear from these patients, like they get immediately relief from the headache, right? So with all this symptomatologically, is all clonidine is a very good drug. We don't have to go for antitussive, we don't have to go for Sinex or fexofenadines. You know, this is all this is all the one drug that need to be treated for the COVID patient. That's what I feel now. And so based upon all these as I keep treating my close near and dear relatives, I come up with these protocols. It's almost like I have 100 patients already, like, and I come up with these protocols. So if you stick with these protocols, I think like it's work well. I never had this complication of hypertension or bradycardia. Yes, the patients did complain of dry mouth and some dizziness, but that's also go away within like few doses, after few doses. So we can initiate the clonidine in any SARS-CoV-2 patients if they have like a fever. If their fever is not subsided by simple analgesic like a Flexon, ibuprofen, and paracetamol. If they have an intense headache, body ache, cough, diarrhea, and yes, definitely a saturation is below 92. And be mindful that we need to check their blood pressure and heart rate. And so here is the number. So what you can do is, like, when the patient have the low blood pressure, that's what I did, like 100 to 119 systolic and diastolic 60 to 79. I started with 100 micrograms HS at the bedtimes, and that's fine. And then, like, when the patient has systolic BP is 120, 139, 80 to 89 diastolic, then I started with 100 microgram BID. And there are the patients population who are already on antihypertensive medications. They have a couple of antihypertensive medications, and their BP is really in the higher range, like 140, 90 above. You know, in those patients, what you can do is you can stop all those antihypertensive medication for a time being and start clonidine, even like 100 microgram thrice daily. So what I found that with the clonidine, the patients get symptomatic relief within 24 to 48 hours. So what I used to do is, like, I used to escalate the clonidine dose every day. You know, like, if not improve by 24 hours, like I step up, and then, like, I regulate their blood pressures, I regulate their heart rates, and then if that number is permitted, if that number is not below 100 systolic and 60 diastolic, and heart rate is below 60, then, like, I used to increase the maximum dose of clonidine unless, like, improvement seen. So I have used up to 100 microgram per day. And then once the patient start getting response, once the symptom get stable, no more fever, oxygen improving, then I continue that dose and for 48 hours and gradually taper down. So 20 to 25%. So let's say if 100 to 200 microgram every 48 hours. So if the patient is in the highest 600 microgram, then reduce to 400, 300, 200, and 100, and then stop. So for the monitoring part, definitely the BP, heart rate, blood pressure, heart rate, and saturations and the temperature should be monitored every 4 hours. So be mindful, like should not start clonidine if the blood pressure is less than 100 systolic and 60 diastolic, and the heart rate is less than 60. And this is the permitted number. In the ICU setup, this number may not work. Even after below this number, also we can with a close monitoring we can give a clonidine. But in the home setup, I think this is the accurate number. And I told them to drink 2 to 3 glass of Zibanjal and take clonidine. And if the blood pressure is low, I take them same amount of clonidine, same amount of the 100 micrograms, and take the Zibanjal. Oral fluid or whatever, and then avoid, after taking clonidine, avoid upright positions for at least 2 hours, and to avoid the dizziness. And for the dryness, I offer them the lozenges to keep their mind, keep their mouth very dry, wet. So I found the clonidine is really effective when mixed, combined with the dexamethasone. When patient have like a intense high CRP with a like a pneumonia with a SpO2 less than 90 and hemoptysis. So as I said, the clonidine is alpha 2 agonist. It's decreased hypertension, tachycardia, cough, diarrhea, anxiety, insomnia, headache, and body ache. And it has a central sympatholytic actions, and it's prevent the catecholaminergic surge and cytokine storm through the neuromodulatory modulations. And we need to be mindful that we have to stop these antihypertensive medication and other sedative and antipsychotic agent. And there is no need of cough syrups, beta 2 agonist, anticholinergic agent, because these drugs, like you see, like these are the commonly prescribed drug for the COVID patients in our part of the world. And based upon what I am speculating, anticholinergic agent or beta agonist should not be used. It will cause more harm. So, and then the role of dexamethasone. So what I used to do is, like, when you start monitoring these patients at the very beginning, you'll see the saturations is 98, 96, all whole day. But with the gradual onset of fever down the road, when they continuously have a spike, and you can see the saturation is gradually decreased and reach up to 92, 91, and there is no more you will see these 95 above saturations. So this is the time point when you have to decide dexamethasone, and this is what I'm doing. Like, I used to start immediately when the saturation drop and reach up to 92. I start them the patient with the low dose dexamethasone, and because, like, we know, like, if we don't interrupt the ongoing local inflammation at the tissue level, then definitely those patients will deteriorate and develop more hypoxia and require oxygen. And we don't want that our patients should go for the oxygen treatment, as it is really scarce. Scarcity is there in our part of the world. So they will die because of lack of oxygen. So this should be, I think, like, we should not wait till the oxygen drop below 90 or 88. And then this is the way how I used to explain to my patients. Like, I used to give the scenario when there is a flooding and when your house is in danger. So there is a two-way to prevent your house from flooding. Like, one, to close the dam, and then another is like build the fence around the house, right? So this is the only two-way. To my patient, that the clonidine and the steroids are most important to prevent the SARS-CoV-2 related complication. So that's all I have to say about this, the role of clonidine in COVID. And this is all my experience, like nothing. And there are lots of speculation because we still have to know how these interactions happen. And since it's working, as I keep learning from treating patients, so I have gained so much of knowledge which I share with you, and I feel really privileged to do that. So besides that, I also want to talk about a little bit about the antibiotic in COVID. So this is the publications which my work um, done in the lab. What I did was, when the mice is fed with the the Western diet, that is obese diet, and then when treated with the antibiotic, and then do the sterile surgical procedures, they develop little septicemia. So what does this mean? So what I did was, actually, in one group of the mice, I fed them this the Western diet. This is a high fat diet. They become obese, and then like treat with the 5 days of antibiotic, and then the starvations, and then did the 30% hepatectomy. So these surgery with are well tolerated by the chow, which is the high fiber diet fed mice. So, but like what you see here is the like a high fat diet fed mice upon with starvations, and then after surgery, when they are treated with the antibiotic, 5 days of antibiotic, 70% will die. Like only 30% are survived. So what does this mean is, antibiotic is really causing harm. And after this experiment, as a surgeon, I feel like I will never ever prescribe high broad spectrum antibiotic to my patients until it's dire needed, because it's causing it's it's very detrimental to their health. It's causing more harm than the benefit. And this is what the result is like. The mice blood, liver, and spleen, they all have this multi-drug resistant Serratia marcescens disseminating in the blood. So this is really striking. Like with treatment of antibiotic, we are not killing the bacteria. There are our gut have like trillions of bacteria, and they are they are just like they are function as an important extra organ. And with antibiotic, we are destroying that microbiome community, where we are killing the good guys, and these bad guys, which are the pathogenic bacteria, they are blooming up, and they are causing harm to our body. They're causing sepsis. This is what's happening. So we should not give antibiotic to the COVID patient also, because what I feel is, and it's already proven, you can see on the literatures, there is no benefit of any antibiotic. Still, like a bigger center in Nepal, they are still treating these our patients with the Duratas, piperacillins. I don't know. Like, yes, there is a consensus of secondary bacterial infection or additive infections, but I would suggest, like, unless there is a strong indication of antibiotic, they should not treat with the antibiotic. That's what my understanding is. And I will sincerely advise you guys also not to prescribe antibiotic. And this is the clinical trials based on the same concept done by the John Hopkins University in the COVID-19 treatments with alpha adrenergic prazosin. So we also propose put the proposal for the oral clonidine to mitigate symptoms in Nepal. So I look forward for your support and participation to make this study successful. With having said that, I would say thank you very much. Thank you for your time.